Good evening, everyone, and welcome to our pregnancy care update. My name is Helene, and I'm the Workforce Officer for West Vic PHN. And working alongside me is Jade, who is also a Workforce Development Officer. This is a 2-hour pregnancy care update, and we'll cover preterm birth, the fetal medicine unit, antenatal care pathways, gynae clinic updates, and colposcopy. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in from today. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respect to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for nations, peoples and organisations, and will work together on closing the gap. Just a little bit of housekeeping. The majority of our webinars are recorded and freely available on our PHN Learn YouTube channel. Jade's got that link up on the screen at the moment. And I have our upcoming events on the screen. You can register for these via our website, and the link is up there as well. Please make note of the West Vic PHN health pathways relating to this topic that is on the screen at the moment. For this evening's meeting, I will ask all the participants to remain on mute for the course, and should you have any questions, please type them in the questions box and they'll be answered during the course of the meeting. They will all be answered anonymously, so just type them in, and questions will be after each speaker. So if you've got something, just type it in and then I'll answer that on your behalf. Our speakers for this evening are Dr. Geraldine Masson and Dr. Tony Ma, Obstetrician and Gynaecologists, and Emily Olive, who's a Maternal-Fetal Medicine Specialist. I will now hand over to Geraldine to begin. Thanks, Geraldine.
Thank you, Helen, and thank you to everybody at the PHN for inviting us to talk today. We've got some really exciting developments that we want to share with you here at University Hospital of Geelong. And my colleagues here are Tony Ma, who's sat next to me, and Emily Olive, who's one of our new colleagues. So, I can't see my slide properly. Okay, so this evening, we're going to touch on the obstetric ultrasound clinics, and Emily's going to talk us through the preterm birth clinic that she runs, and I'll talk about the fetal medicine unit. These are both here at the University Hospital of Geelong. We'll then talk about the Rainbow Clinic, which is a clinic where we review our women who've had a late pregnancy loss, either a termination for fetal anomaly or a stillbirth. And we'll talk about the maternity debrief clinic that's just started here as well. We'll then go on and talk about the updates in our antenatal clinic service, and a lot of you will have received the new guideline around this. And then I'll hand over to Tony, and he'll talk about the public gynae clinic and colposcopy. So quite a lot to get through. Now, obstetric ultrasound clinics. Here you'll see myself and Emily Olive in the photo on the left, and Ahmed Alamin in the photo on the right, with Edwina McLean, who's one of our fetal medicine midwives. We're standing very proudly next to our new ultrasound machine, and we are hugely indebted to the Barwon Health Foundation, who quite literally bought me my biggest Christmas present ever. Their fundraising appeal last Christmas was to buy this machine, which comes in at $250,000, but this is what has made setting up all these clinics possible. It's state of the art, it's beautiful, and it's going to make such a change, such a difference to our women here in Geelong, and hopefully within the southwest area as well. So I'm now going to hand over to Emily, who's going to talk to us about the preterm birth clinic.
Hello everybody, and thanks for tuning in after work on a Thursday. I'm new in Geelong at the hospital, and I'm very pleased to have made the change, and it's been a very welcoming community, so thanks for contributing to that. My first slide here is one of my mentors and a very well-respected Australian obstetrician. In fact, he was the Senior Australian of the Year a couple of years ago. It's John Newnham. He is a obstetrician and fetal medicine specialist from Perth. And John's major contribution in the last decade has been with a statewide program that he's set up in Western Australia, which is now being rolled out nationally. And in Western Australia, they called it the whole 9 months. And the purpose of that, it's a catchy marketing slogan, but the point was to try and encourage all women to aspire, and their caregivers, of course, to getting pregnancies to term. John's quite keen on the expression, the low-hanging fruit, and for him that was trying to make sure that the 36, 37-week deliveries that perhaps were a little bit iatrogenic didn't happen, and that women stayed pregnant, if at all possible, until 39 weeks, because we know that longer-term outcomes are much better for children if that is achieved. But we're now looking forward to seeing what we can do at all gestational ages to improve on the gestational age at which children are born, because it's massively effective and cost effective in the long term for our Medicare budget as well. Next. If you look a little bit more closely, this is just from the Preterm Birth Network website at How Does Victoria Go? You can see that it's about 8.5% of, I'll put my glasses on, of all babies in Victoria do come early. So that's about 6,500 babies annually in Victoria. And so most of those are late pretermers. It's about 1% under 28 weeks and another 1% between 28 and 32 weeks. And of course, those are the most expensive babies. But if you look at the whole budget, it's probably the late pretermers that contribute the most because there's just more of them. So we're all working hard to try and reduce those numbers. Next. So if you try and pick, you look at your antenatal population and think, okay, well, who's the woman who's likely to have a preterm birth? And you can see that number 1, 2, 3 are all things that you can pick on your history rather than anything that happens in her current pregnancy. So in particular, it's the teenager more than the older woman. The women in their 40s tend to have preterm births, but they're much more likely to be the indicated preterm birth due to hypertension or diabetes or multiple covariates. But it's the 16-year-old who's particularly at risk, and of course the teenagers tend to be at risk for socioeconomic disadvantage as well. In our Geelong population, we also have high levels of obesity, and so that can be another covariate that's unhelpful. But it might come as a surprise to you to find that it's not actually the obese women who are most at risk of preterm birth, it's the very, very thin girls. So if you have a BMI of 18 and you're 16 years old, you really deserve a red flag and you should come to preterm birth clinic. More traditionally recognised risk factors are if you've had a preterm birth before, that does increase your risk the next time. But remember that if your preterm birth rate is 8% and you double it and say, well, it's 16%, that's still a vast majority of women who in the subsequent pregnancy will deliver at term. So it's not an automatic thing that a previous preterm birth destines you for it to happen in every pregnancy. One of the risk factors that's actually become much more discussed and there's been much more concern about in the obstetric literature is increasing numbers of women who've had a previous caesarean section at full dilatation. Now, this might be because we're getting a little bit more wary about mid-cavity forceps deliveries and perhaps the skill levels are less good, but for whatever reason, if you're fully dilated when you have your caesarean, it means the incision in the uterus is quite likely to be in the anterior cervix and that this will confer some damage and risk of early severe preterm birth in the subsequent pregnancy. And so those women really need to be flagged to have a careful look at their cervix in the next pregnancy. And you all know that if you've got twins or triplets, you're going to deliver early. The median gestation of a twin delivery is at 35 weeks. For triplets, it's 32 weeks. We can do something about that. It's not automatic. And even if those babies still come early, if we can get them to 35 instead of 31 or 29, then that's a much better outcome. So any gain is worth having. Next. This is a picture from the recent census data. It's a map of Geelong. I'm expecting you all to recognise that. And looking at socio-economic disadvantage. And I suspect that most of you will know, because you probably see it day to day much more than I do, that there are pockets of severe disadvantage in Geelong, and that of course has flow over into our preterm risk population, and indeed our local numbers, at least for the 32 to 36 week group, are higher than what we would expect in other areas, and this is probably reflective of our population. Next. Looking at the Bureau of Statistics data, census data again, you can see that the local government area with the largest Aboriginal and Torres Strait Islander population is Greater Geelong for Victoria, so it's about 3,500 people of that background in our area, and Indigenous women have a higher rate of preterm labour. So some of these factors come together, but we particularly need to look after these women and try hard to do what we can to make their babies come at term, because it's a major driver in improving their outcomes. So half of all preterm births happen in the first pregnancy. So you're not going to be able to use those risk factors of the previous preterm birth or the previous cesarean. You really need to be cognizant of those socioeconomic factors, because that's all we've got to go on. And so what we can really do is to concentrate on the mid-trimester scan, because almost everybody, no matter how poor they are, tend to have that scan. People, you know, if they're going to miss any investigations, it doesn't tend to be that one. Next. This is a picture on the left of what it looks like at the mid-trimester. This woman was 20 weeks and 4 days gestation. And what you're looking at there, this is in the operating theatre, looking down the speculum, and you can see that the cervix is open. There's a bit of a reflection from the posterior speculum there, but that's bulging membranes. So this woman was about 4 centimetres dilated at the time that that picture was taken. And she'd actually been sitting in the delivery suite for a couple of days, and people had just been saying, oh, well, she's going to lose the baby. And in the end, we thought, no, we were prepared to take her to theatre and give her the option of an emergency cerclage. This is either brave or stupid. But in any case, I put this stitch in. You can see on the right, it's not a high-tech operation. She had a purse string closure of her cervix with a 1 nylon stitch. And you can see we've achieved closure of the cervix, and she's sat in the ward for a few more weeks. Next picture. This is her little baby. So he was born at 24 weeks and a couple of days. He was 400 grams. On the right, you can see him after a few months, still in hospital. He went home at about 10 months of age, still oxygen dependent. And mum's very happy, but this child has long-term disability with close to complete blindness, and obviously will need ongoing care for the rest of his life. I think this is just a salutary tale that maybe if we'd seen her a week earlier when she had some cervical length, we might have been able to get this pregnancy a little bit further on. But it also shows the difficulty in, did we do this family good or not? Mum feels so at the moment, but you can imagine it's a very complex decision, and it's very difficult at these very early preterm gestations to know what's best to do. Next picture. So what can we do? It's all about cervical screening. Carry on. So going back to John Newnham's Preterm Birth Prevention Alliance, this is one of the key practice points, is that at the mid-trimester scan, everybody should have their cervix measured. John had some fairly cheeky posters that were up around Perth that everybody deserves to know the length of their cervix, and that sometimes length is important. And what you can do as GPs when you're writing these referrals is remind women, get them to nag that they really need a transvaginal scan, because that's the best, most accurate way to measure the cervix, and it's really important. To be honest, this is actually probably more important for the pregnancy outcome than trying to see what the cardiac anatomy is, because we know that we're going to miss half of all cardiac abnormalities. But if we can at least measure the cervix properly, we have a chance for evidence-based intervention, and that will probably have a better impact on the pregnancy than trying to review all of the anatomy, because we're not that good at that anyway. Next. And just go on to the next one as well, Geraldine. That doesn't project very well. The graph on the right is showing that the cervix is normal until it's not. So basically, as long as you've got a cervical length more than 2 centimetres or 20 millimetres, you may well not have any significantly increased risk of prem labour. But you can see how it really shoots up the shorter the cervix gets. And of course, there's a bell curve in normal cervical length. So most women at 20 weeks gestation usually have a cervix that measures about 30 to 35 millimetres, which is entirely normal. And you can send those women away saying they have a low risk of preterm labour. For that group of women who have a cervix of 20 millimetres, it may well be normal for them, but they do warrant a review. And for those who are 15 millimetres, it's probably not normal. And what we don't know is that the length that that woman normally has, or is it on the way down? And if we'd seen it 2 weeks prior, it was 30 and now it's 15. And so we need to be able to differentiate by seeing those women again, and that's the whole point of a preterm birth clinic. Next slide. I just thought you might be interested to see, this is from the main obstetric ultrasound journal, and just incidental wins, and you do actually see these. I've picked an unexpected vasa previa, the image on the left once before. So this is where there's a fetal blood vessel that's errant in its course and tracks right over the internal cervical os. And if this is missed, that baby usually will die when the membranes rupture, because it will exsanguinate. And by knowing about that, you have the opportunity to intervene with a caesarean section. So part of my teaching of transvaginal ultrasound is that there always needs to be a colour box put over the internal os. The picture on the right is a placenta previa that is not subtle. You would have seen that on abdominal imaging, but this is the best way to look at the decidual interface and to try and judge whether there's any abnormal adherence. And for those working in a rural or a regional setting, that's important because it might help you differentiate which woman you might send to Melbourne for the high-tech interventions that we might not have locally. So, big fan of transvaginal scanning, and please encourage all your patients to be expecting it and to ask for it. Next. Last year, progesterone was listed on the authority list as a proven treatment for preterm labour. So it's a vaginal pessary. I phoned around a few chemists in Geelong the other day just to be sure that everyone was charging the same thing, and they are. It's $42.50 for 42 pessaries with 3 repeats, which should be enough to get anyone through the pregnancy. And for women with a healthcare card, $6.80. So I don't really think that cost should be a reason not to have progesterone for that select group who have a short cervix. It's well tolerated by women. I just ask them to pop one in the vagina when they brush their teeth at night, and it's a little bit messy, but people are pretty well accepting that it is effective. And what you tend to see is that the cervix, it doesn't get longer, but it stops getting shorter. And it's pretty impressive when you see that on chart. I think I've got a couple of pictures to show you of that. Next. That's just a picture of inserting a stitch. I don't think I need to talk about that. Carry on. Next one. This is what it looks like on the left there. There's a little cartoon showing how a vaginally inserted stitch looks. It's just a purse string. It's not fancy surgery once you're used to operating in the vagina. And on the right side, you can see what a stitch looks like. Geraldine can point out the 2 little white dots, which are the stitch in cross section. And the black area above that is the amniotic fluid. And you can see that the fluid is still funneling down towards that stitch. So probably without that stitch being present, that baby may well end up with preterm ruptured membranes, which is a concerning antecedent to preterm birth. Next. This is just a demonstration of a win and a very happy big brother here. So the chart on the left is from Viewpoint software. That's what we're using at Geelong, and it's lovely because you can see over time the impact. So you can see this woman started off with a normal cervical length when she was about 18 weeks. And she had a bad history. And so I kept bringing her back to clinic. And you can see over the next 3 visits, her cervix progressively shortened. She was on progesterone at that point, but despite progesterone, her cervix continued to shorten. And when it was less than 10 millimeters, we know that progesterone is less effective, and she had a cerclage placed. And from then on, the cervix, the length improved. It stayed abnormal, but it stayed, it didn't worsen again. And she went on to deliver at term, and she had a healthy baby boy at term. So she's a success story for continuity of care for progesterone and cerclage. Next. This is not within our scope of practice, but I just thought you might be interested to see. This was a private patient of mine who had a terrible history. I'd placed a vaginal suture. You can see it in the left picture there, but above it, there's still funneling from the internal os down to just above the stitch, and there's some sludge in the canal. That pregnancy failed. And so that was her second loss with a very strong history of cervical incompetence. And in the right-sided image, what you're looking at there is a suture being placed abdominally. So in between pregnancies, she had a transabdominal cerclage sited. And you can see the 2 little white dots there. That cerclage is placed so high, you could never get that in place with a vaginal approach. This is a trial proven benefit, but for a very, very small group. And my only beef with this surgery at the moment is that it's applied too widely because there's morbidity putting in these stitches, there's ramifications should she have an anomaly in the next pregnancy and need a termination, and she does need to be delivered by caesarean section. So a good therapy, but for a very, very small group of women who have failed the less invasive procedures. Next. That's just a slide to show you that there's a lot of ongoing studies being performed looking at the concerning finding of full dilatation caesarean section. And we need to be mindful of that because we're now doing increasing numbers of these full dilatation caesars. And so I think it's a bit of a minefield problem for the future. And it's going to entail an increasing proportion of our preterm labour clinic patients. Next. One slide here just to show you the importance of twins to our preterm births and the impact of chorionicity. So chorionicity refers to the number of placentas that a twin pregnancy has. And on the left, the dotted line that deviates in a very downhill fashion over gestation is to show you the impact of monochorionic twins. So these are the twins that share a placenta. These are most of the identical twins, and the little 3D picture there shows you some identical twins there at about 10 weeks gestation. These babies in fact do have an amnion in between them, but it's very fine and you can't actually see it there. So those twins are the very highest risk because they deliver so early. Some of the reasons they deliver so early we can do something about, some of them we can't, but some of those risk factors all get together. But that particular group are very high risk and should be referred in for a combination of preterm labour surveillance and fetal medicine. They fulfil criteria for a couple of our clinics. And what we hope is they don't also fulfil criteria for Rainbow Clinic. Next slide. So what can you do? Opportunistic input. I mean, not so easy to fix smoking and obesity, but do what you can. And I just ask that try and flag to yourself when you see someone, if they've had a previous preterm birth, if they've had a caesarean late in their labour, try and remember that in another pregnancy, that woman will be at risk. And if you can just put an asterisk against that name to be sure that that girl comes to preterm labour surveillance in her next pregnancy, that would be a really good thing. The other subgroup that you won't know until the pregnancy, but one of the very highest risks for early preterm birth is bleeding after 12 weeks. And I really, really want to know about those ones because we can do something about them, and that's not well recognised as a risk factor for preterm ruptured membranes, but it's one that I'm trying to educate our registrars and our emergency staff about. So that's a really important one if it happens. Next. This is just a slide from a teaching article about how to do vaginal scanning. It's not quite as easy as you think it might be, and I've found that it normally takes about 20 scans for our registrars and midwives to be competent at vaginal scanning, at cervical length screening in particular. And this is just one of the perfect images to show from a teaching article. But we're progressively trying hard to teach everybody, and I'm very, very open to teaching anyone who thinks that there would be a benefit for them, and to negotiate a time if you would like to avail yourselves of that. Next. So this is our little flyer for the preterm birth clinic, just recapping what we've already talked about. The risk factors that you can see prior to pregnancy and those that might be only relevant in the current pregnancy. I've put my mobile number there. Very happy to have a text message from any of you or to chat over a case if there's anything that you think I might be able to add to try and improve this outcome. Preterm birth is not a binary outcome. It's not a yes/no. Any gain that we can get is super important. And so turning a 27-weeker into a 29-weeker really, really makes a big difference. And I just encourage you to help me in trying to improve outcomes for our women. That's me done. Any questions right now, or shall we carry on?
No, thank you very much for that. I have one question. Should we refer all women who bleed after 12 weeks? Any investigations?
Yes, please. I guess I just want to be sure that you understand that this is different to, an 8-weeker with a miscarriage that could be for any other reason. So we want to see women for whom aneuploidy and first trimester miscarriages have already been excluded. But the typical woman who will come in with bulging membranes at 20 weeks will come in and say, I've just had a little bit of increased discharge. I've just had a bit of spotting. I think everything's fine, but I just want to check. And, they're sort of apologising for coming in, thinking, I don't want to waste your time. And then you put a speculum in and they've got bulging membranes. That's the typical presentation. But normally when you quiz them, they say, I've just had a bit of spotting for a few days. And the thing that makes me cry is often they've presented twice already and the registrars have, listened with a dot tone and sent them home again. That should be a major red flag. So if you have someone who comes in anywhere between 16 and 24 weeks saying, they've just had a bit of spotting, please let me know.
Okay, and refer to PCC or somewhere else?
At the moment we're using that email address. I don't know if you can see it on the bottom of that flyer, which is just the generic fetal medicine referral. So you can use that, but as I said, happy to have a text and always happy to squeeze someone in. I mean, it's a 5-minute ultrasound, and a lot of the time you can say, yep, you're good, and off you go. But that you can really make a difference if you catch them in time. So I'd always prefer to check and have it as an overcall on the original one.
Okay, thanks, Emily. I don't have any other questions at this stage, so we'll move on. Thanks, Geraldine. Oh, hang on, there's one just come in. What about spotting after intercourse? Still high risk, ? I feel like I remember at the Royal Women's Hospital ED them saying this was normal, in brackets, although I can't say I've had women with this since.
You don't really know until you look. So I think if someone's spotting at 34 weeks, you might not be so interested. But if it's in that, particularly, 15 to 22 weeks, I am interested, and I want to see them. You can have some big wins if you get them in time.
Great, thanks, she said. So thanks very much, Emily. Now, Geraldine, over to you, thanks.
So thank you, Emily. I don't think we quite introduced you properly. Emily's maternal-fetal medicine specialist, and we're incredibly lucky to have her in Geelong. And she's done a great job in setting up this preterm birth clinic, which I think is the only one outside of Melbourne. So this is great for our women because they need scans fortnightly, and that's really tough for some of the women particularly with those concerns relating to social determinants of health. So thank you, Emily. Thank you for coming to Geelong. All right, so I'm going to run through the fetal medicine unit. Again, I think this is the only fetal medicine unit outside a tertiary centre in the whole of Victoria. I may be wrong. And we have only just started. We've had a few glitches with IT and the software and things, so we haven't come out in a blaze of glory quite yet. But we are taking women in, and we do have 4 scans a list between myself, Emily, and Ahmed. And what I'm going to do is just take you through the indications for referrals to the fetal medicine unit, and we can talk through those. So the first bit is around the history from the woman. So a history of a previous congenital anomaly. So if she's been cancelled after her previous loss, there should be some sort of plan around what she would require in a subsequent pregnancy. Maybe early scans, maybe targeted fetal echo if it was a cardiac anomaly. It really depends on what that anomaly is. A history of somebody who's a known carrier of genetic disease, either because they've had a child that's been affected before, and then a history of a condition where the mum's probably got a condition that might have a significant fetal impact. The other list of indications for referral are problems that are identified in the current pregnancy, and a lot of these will come through to us just because we're looking after them in the pregnancy care clinic, and so may not impact on you directly, but it's if there's a structural difference on the ultrasound scan at any gestation, if they've got an NT greater than 3 millimeters, an abnormal NIPS or early screening, severe early onset of growth restriction before 32 weeks, ingestion of category X drug, twin pregnancies, and Emily mentioned monocurrent twin pregnancies. These need to be scanned fortnightly through fetal medicine to identify those babies that have twin transfusion syndrome, and then they would get referred up to Melbourne for further management. We don't particularly scan dichorionic twin pregnancies unless there's evidence of significant discordant growth, and then higher order multiples because they're just problematic. So previous congenital anomaly, is there a plan from the previous pregnancy? Have they had follow-up counselling, and was there a suggestion at what point they needed to be referred in? If you get a letter from any of us, we would outline a plan for the next pregnancy because that's what parents want to know, and we would tell them what the chances of this happening again is, and that would impact on whether this is important for them or not, and whether this is an anomaly that we would be able to detect on scan, or whether we need to do a different test to try and work out whether we've got another affected child. And are there any interventions that are helpful? Some, well, for example, with Emily's preterm birth clinic, the intervention that's helpful is a cervical cerclage and a progesterone pessary. And also, how are we going to support the parents if they've been through a pregnancy where they've had a poor outcome? They're going to be really, really anxious. And part of coming through fetal medicine is actually providing that supportive environment where we can reassure them at various stages through the pregnancy, as we can see more and more of the baby as it gets bigger, that the concerns that they had with the previous pregnancy doesn't necessarily apply this time. For example, somebody who, say, has had a baby affected with trisomy 21 in a previous pregnancy, the recurrence risk is about 1%. And between scans and other investigations such as NIPS, such as maybe invasive testing, then we can reassure them. And then by 15, 20 weeks, we may be at a point where we can actually say to them, this pregnancy is absolutely fine, go away and enjoy it and be low risk, or we can keep them through the clinic. So a known carrier of a genetic disease. So this will either been picked up because they've had a problem in a previous pregnancy, and in that situation, you would expect that they've had some sort of genetic counselling. If they've had a previous trisomy, the recurrence risk of those is about 1%. And so then the conversation is, are we going to do a screening test, or are we going to do a diagnostic test in this pregnancy, or are we going to see what the baby looks like before we do anything else? Something like Turner syndrome, interestingly, the recurrence risk of that's 1 in 1,000, so it's really low. They may be a carrier of a genetic disease like an unbalanced translocation, and the recurrence risk of that's about 50%. So in that situation, they may choose to have invasive testing, or they may choose to have pre-implantation genetic diagnosis. I'm sure all of you are familiar with Prepare, which is genetic carriers screening. And what Prepare does is it identifies couples or dyads who are high risk of common genetic differences through genetic carrier screening. So what is the, what is the plan? What is the plan for this pregnancy? Do they want screening? Do they want investigations? Are we going to screen the embryo before it ever gets implanted? So Prepare, for those of you that don't know, is a blood test, and the basic Prepare is test for 3 common differences. So cystic fibrosis, which has there's a carrier rate of 1 in 22 in the population, spinal muscular atrophy, and Fragile X syndrome. The baby on the right is Mackenzie, and Mackenzie was born with spinal muscular atrophy, and she died when she was about 10 months old. And their parents have pushed really, really hard that genetic carrier testing is available to all, and there was something like $20 million put into a research project for testing, and I'm not actually sure where that's got to, but I know that recruitment had closed. Anyway, Prepare's offered by VCGS, and what they suggest, if you're going to have standard Prepare, it's $389 for each person being tested, but they suggest that the mother gets tested first, and if she isn't a carrier of any of these conditions, then they suggest that her partner doesn't get tested. But if she is a carrier, then they'll test the partner as well, and the results come back in about 2 weeks. They only give a result on a dyad, so on a couple. So if she ends up with a different partner in the future, then that new partner would also need to be tested. They also offer Prepare Plus, which tests for 250 conditions, and this costs $900 per couple, and they just ask you to provide both samples at the same time. It takes about 6 weeks to get the result for that, and ideally you want these tests to be done before the couple ever get pregnant. We do discuss Prepare with pregnant women in the first trimester, because they've still got an opportunity to investigate further. But I would suggest that ideally this is done before they get pregnant. Prepare is not covered by Medicare or private health insurance in any shape or form, so the parents are paying for this. So if there are known carrier of genetic disease, what is the actual underlying genetic condition and what's the recurrence risk? Is there a screening test or do the parents want a diagnostic test? So for example, if they had a baby with Down syndrome in a previous pregnancy, their recurrence risk is 1%. And there is a screening test available, which is NIPS or combined first trimester screening. And some parents would choose to go down that route, and other parents may choose to go down the invasive carrier diagnostic testing. If they're in a situation where they've got a 50% recurrence risk because they've got an unstable translocation, a balanced translocation, which would then potentially cause an unbalanced translocation, have something like pre-gestational diagnosis been considered. So the prenatal diagnostic genetic testing that we offer in the service are amniocentesis and CVS. There are pros and cons of both of them. Amniocentesis is probably felt to be a less invasive procedure because we're collecting amniotic fluid from around the baby, as opposed to in a chorionic villus sampling, we're collecting chorionic villi, which is essentially placental tissue. But the advantage of CVS is that it can be performed earlier in pregnancy. So if you've got somebody who's got a combined first trimester screen, which is giving them high risk of a trisomy, then they would probably choose to go down this route if they're sitting at 12 weeks. However, if their results come in at 14, 15 weeks, they may go down for the amniocentesis. Now, the one thing that parents are very anxious about with having invasive testing is the risk of miscarriage. And when I started out as a junior doctor, what would happen is a woman would go down to the ultrasound department and they'd scan her and they'd put a big cross on her abdomen and then send her back to the ward. And the consultant would then take her to theatre and put her on all fours and give the pregnant abdomen a bit of a jiggle to kind of stir up the amniocytes and then turn her over and then stick the needle in where the cross was. Now, I've done a huge amount of amniocentesis, and the number of times I've had to wait for a baby because it's moved into the spot where I was going to stick the needle are too many to count. And the procedure-related loss in the past has been reported as at 1%, but the way we do it now is we do an ultrasound-guided procedure where we scan, find a nice pocket of fluid, and stick the needle in and watch the needle the whole time it's going in, collect the fluid and pull it out again. And the same for CVS, it's ultrasound guided throughout. And there was in the ultrasound of the Gynae journal, Salomon et al. Published a paper which is a meta-analysis of all the studies of procedure-related losses for invasive procedures. And it's really, the risk is 1 in 1,000 for amniocentesis and 1 in 500 for CVS, and the rates are much lower than we all quote. So structural difference on scan. We're doing anomaly scan, well, we're doing early anatomy scans from about 14 weeks, more and more out around and about, but the morphology scan really is done at about 20, 21 weeks. We're checking to see whether the baby's got everything that we would expect it to have in the right place, and that it doesn't look funny at all. But if there is a difference on the scan, then that requires further investigation. Is it an isolated difference, for example, like a clubfoot, or does that clubfoot have other differences that maybe not have been picked up already? So it does require that somebody has another look in greater detail and with a bit more time rather than the time that's just allocated to a normal morph scan. And then, so this is a nuchal translucency scan, and this is what we measure the fluid at the back of the neck when we're doing the combined first trimester screening. If you've got an increased nuchal translucency of more than 3 millimeters, that's a huge weight in terms of your risk of a trisomy when it's aligned with the serum markers. However, it doesn't necessarily mean that baby has a trisomy, and many will come back and not actually have a genetic difference. But this is still important, and these babies need to be scanned, particularly around looking at cardiac differences, because there is an association with increased nuchals and cardiac differences. Abnormal NIPS or combined first trimester screening. So combined first trimester screening, you're measuring the nuchal translucency and measuring serum markers to give you a composite risk of trisomy 13, 18 and 21, and that'll come back as we take into account the maternal background risk, and then using these markers either increase or decrease the chance of that baby having a trisomy. Now, the kind of mathematical principles or the software that's used to get to that point is very similar to when you're buying car insurance. So the car insurance company will have a platform, and if you've kind of run a few red lights, your insurance will go down. But if you've never had an accident, it will go up. But if you've never had an accident, it'll go down again. So there's a composite number of factors which will adjust that, and then you'll get to a pregnancy specific risk for that woman. What many people are doing if they come back high risk with a combined first trimester screen is that they're then going on to do a NIPS or a NIPT test. But what you have to remember is a NIPT test is also only a screening test. And if that then comes back with a risk of Downs, for example, it may be in the high 90s, but it's not 100%. And interestingly, today I scanned somebody whose NIPS has come back as monosomy X, but that's a little boy on scan. So this is not completely reliable, and this is why we don't end pregnancies or make decisions about what's going to happen based on NIPS. We still require to have an invasive test if they want options around ending the pregnancy. So ingestion of a category X drug is another reason for us scanning in fetal medicine. And what we really need to know is what drugs have they had, when have they had it, and what sort of dosage have they had. If you think back to the thalidomide disaster, which happened before most of us were born, and I think I dodged a bullet there because I was born around the time it happened. Not every baby was affected with the drug, and it really depended on what gestation that woman took that drug and whether it was a point at which the limbs were developing and was likely to impact on that. So if you've got a woman who's taken drugs early in pregnancy because she's wasn't expecting to get pregnant, then a really good drug history is really helpful. One of the other things to consider is if you've got women with chronic illnesses and they're taking medication, and when you do that annual checkup, ask her if she's considering pregnancy in the next year. And if so, and if she says not, then say to her, well, if you do change your mind, come and talk to me about your medication. It's worth looking at whether you should change drugs. For example, if you've got a woman with diabetes, changing that over, and it's maybe on statins or ACE inhibitors, thinking about stopping those drugs because they're really not recommended in pregnancy, and moving them onto, if you're stopping the ACE inhibitors, for example, moving her onto a pregnancy-friendly antihypertensive agent. The other thing to be aware of is polypharmacy tends to create many more problems than single agent. So if you've got a woman who, for example, is an epileptic and is on 2 or 3 agents, that's much more likely to have an impact on fetal development than if you can get her onto 1 agent. And the website address that I've put on the screen is a really great resource. It's about the best use of medicines in pregnancy, and this is actually, it's run by the UK Teratology Information Service, and they have an ongoing review of the literature, and they're constantly updating the current evidence. The Medicines in Pregnancy website gives you a resource to patient information leaflets in terms of the drugs that they might be taking. And it's freely available, and you just go on there and print out these leaflets. The only small problem is some of the drugs in Australia have slightly different names to what they are in the UK, but that's the only small problem. But I haven't found anything similar available in Australia. So if you want to refer somebody to fetal medicine, there's a fetal medicine referral form in which you emailed and fill out the form, put as much information on there as possible, and you can email that form to the fetal medicine email address, or you can call us on the number which is the same number as the pass phone number. Not all referrals will be accepted. For example, we had a referral last week that slipped through where the woman had a PDA and she was sent through for a fetal echo. Now, all fetuses in utero will have a patent ductus arteriosus, otherwise they wouldn't really survive pregnancy. So it's actually, that isn't really the sort of congenital anomaly that we could easily pick up, because that's dependent on postnatal changes. So if it's something that we don't think is going to be very useful, then we might just redirect the woman to a clinic where a discussion can be had around the situation and what would be useful to have. Okay. One of the issues that we've had in the service is in University Hospital Geelong is that sometimes sometimes there have been problems picked up on scan in BMI, and then they've kind of got lost in the ether. So we've now got an escalation policy for women who are, only pregnant women who are booked at UHG, where if there is a concern on the scan, then that can be directly referred through to us. And if it's a critical situation like a fetal bradycardia or an abruption or something, that would get referred straight through to birth suite. If it's an urgent issue, a concern about a fetal anomaly scan, for example, that'll be referred through to fetal medicine unit, and we'll triage and arrange a scan as soon as is practicable. The important ones is cases like growth restrictions with abnormal Dopplers and things. They'll be triaged to be seen within a week or so. And then if there's no concerns at all from the scan, they'll just be seen in the routine clinical appointment. But anybody who isn't booked at birth at UHG, who has a scan at BMI and there is a problem identified, because of confidentiality issues, BMI will be sending that information back to you as GPs, and then that's what you'll need to do is you'll need to decide whether you're going to refer them through to us or whether you're going to refer them through to UCFW down on Little Ryrie Street or maybe up to Melbourne. Does anybody have any questions about the fetal medicine service? Maybe you'll have some at the end. Okay. So we have a couple of clinics.
Sorry, Emma. Sorry, Geraldine. I do have some questions. Do you want me to read them out?
Yeah, you can. Well, I can. Yeah, go for it, and we'll talk about the fetal medicine ones.
Should we offer Prepare as well as Percept NIPT in early pregnancy?
Prepare is looking for different things to Percept, because Percept is looking for trisomies. Yeah. Okay. Yeah, Percept. So Prepare is looking for Prepare is looking at whether that couple are at risk of having a baby with Fragile X, spinal muscular atrophy, or cystic fibrosis, and they're things that can't be picked up with Percept. Percept is a screening test looking for trisomies and sex chromosome differences. So they're two completely different tests. And yes, we should offer Prepare pre-pregnancy. But we would offer them when they arrive with us in pregnancy clinic if they arrive early enough. But we don't have access to women before they get pregnant. So that's when you should offer Prepare. But Percept is an entirely different thing.
And one more question.
Yeah.
Can that referral for FMU be made available to GPs as a template for best practice, please?
Yeah, I think that's the intention. But yeah, so that is the.
We will have to talk to the
Okay, and just going on from that other question about the Prepare and Percept. So if they have not had pre-pregnancy planning, we offer both in early pregnancy. That's a question.
Yeah, yes, I would offer both. It's up to them whether they take them. But it's our responsibility to make sure our parents are informed so that they can make their own choices. But yeah, they can do Prepare early in pregnancy. Yeah.
All right. And the audience couldn't hear what Tony was saying then. Was there anything you wanted to repeat that Tony had said?
It's about the fetal medicine referral form. At the moment, that would need to go through the GP liaison and have a conversation there. But you could, you can email the fetal medicine unit. But you could also put it through on the pregnancy care clinic, because we're actually based in pregnancy care clinic. And if Lauren Langley picks up any referrals that suggest that they might need fetal medicine, she just comes to us and asks us.
Okay, very good. Yeah. Okay, yeah, no more questions.
Okay, cool. Okay, so moving on. So in tandem with the fetal medicine unit, we also have a rainbow clinic. So rainbow babies are the babies that you have the next time. But what the rainbow clinic is really a follow-up clinic for women who've experienced stillbirth or termination for fetal anomaly. Now, what we do at that clinic is we review the notes. We review all investigations that are done at the time of the stillbirth or the termination. And if there's an autopsy or histopathology of the placenta, we look at that as well. And from that, we work out what's gone on. So really for the stillbirth, it's trying to work out why this baby died and is there anything else that we can do to maybe improve or reduce the chance of it happening again in the future. And to work, and if there is something that's likely to happen again, work out what we can do to mitigate against that. Termination for fetal anomaly, that's just going through. Sometimes we will end a pregnancy, say because of a cardiac defect, and then they go on and have an autopsy which has found more things, and we can just talk them through the results of that. And when they come, we talk through what the results say, but we also talk through their experience around the bereavement. We talk about the baby in terms of its name. We'll check how where their baby went, whether they had a burial or information, and we'll check whether they've had any bereavement counselling. The Rainbow Clinic is a one-off appointment. It's not. It's an opportunity to get information, but it's not actually bereavement counselling. And organisations like Hope Bereavement would do a really good job of providing that. But the other thing that we do in the Rainbow Clinic is plan for the future pregnancy. So we tell them what tests they could have next time, how we would help them, how we would support them through the pregnancy, whether they need any extra scans or not. And then what I do is I write a letter to the parents, and in that letter I will cover the things that we've discussed in the appointment and any findings that have come up from the investigations. And I will also put in their plans for future pregnancies. And I will send, so that's written to the parents, and I will always send a copy to the GPs so that they can see what's been suggested and what plans are available for next time. Where are we? Okay, and this week is Birth Trauma Awareness Week, and 1 in 3 women will experience the birth of their baby as being traumatic. And we do quite a lot to try and support women, to try and inform them about the sorts of things that might happen. We have birth preferences where we talk about their choices in labour and try and give them some realistic expectations around that. But despite that, women often find the experience traumatic. And this is 1 in 3 women in your practices, and they may not have had a terrible, they may not have had a terrible time that we assign as a terrible time. But one of the women that I've seen that was hugely traumatized is somebody who came through the door and got onto the birth couch and had a baby within about 5 minutes of walking through the door. Now, the chat in the coffee room then is, oh, that was a great labour, wasn't it? She just came in and had the baby. But she was very traumatised by that because she hadn't really kind of come in and settled down, and the pain was intense for her. So what we would assume is traumatic isn't necessarily the case. One of the other things that we need to think about is dads also experience trauma. They're often sat in the corner of the room, and if an emergency happens, there's nothing that they can do practically, and they've got no control at all of what's going on. And the love of their life, their partner is going through some traumatic experience that they just can't help with, and they just feel helpless and powerless. And so about 1 in 10 of dads will have long-term problems. And both of these, both mums and dads, it's a form of PTSD, really. So anyway, this week is the Australasian Birth Trauma Association's Birth Trauma Awareness Week, and I think the Birth Trauma Awareness Day is on Sunday, which is the 24th. And this kind of is, how did my birth go? I almost bled to death. It was scary. I went to theatre, had a blood transfusion, and now the baby's here. I don't know how to feel. Women are, you come and have a baby, and there's this expectation that it's going to be a great experience, and this baby's going to be put in your arms, and you're going to have this overwhelming love for this small being, and then you're going to go home and play happy families. But it isn't always like that. And when they get home, quite often they're isolated. Women don't always have a big circle of support, and many of their friends will be at work and not available to come pop in and see them through the day. There's, this woman who has done everything that she feels was right. She looked after herself. She went to yoga, but then ended up with an emergency section, and now she feels that stole the moment of her daughter's birth. She's got huge expectations of what would happen, and then and then for whatever reason that's been taken away from her. And there's this feeling of guilt. We had somebody recently on the birth suite who had what was probably one of the most difficult shoulder dysplasias I'd ever delivered, and luckily the baby came out and the baby's absolutely fine. But I was really concerned about both of the parents, but they had been to hypnobirthing, and one of the things that they said was they had this mantra which was about acceptance, and it was whatever journey my birth goes, I will accept. And so although they were hoping for a particular experience, the hypnobirthing course had really prepared them well that you can't always plan for what happens, and you might end up in a situation that's unplanned, unexpected, and tricky. And really the most important thing is that we have a healthy baby and a healthy mum come out of this, but often, like we say, parents are traumatized. And then this one, it's, you know, the birth was easy, but nobody prepared her for the fact that the baby had a pneumothorax and had to go to NICU. And she just feels lost and doesn't know what to do. Nobody prepared her for having a NICU baby. So please just be aware when your women come into you for their checkups postnatally, just touch base and just ask them how they're doing and how they're going. So maternity debrief, this is one of our other debrief clinics. But maternity debrief really, I think, starts in labour. We should be explaining what's happening with the labour as it's occurring, and explaining to women what's happening, why we're doing things. If we end up with an emergency section, they should be well aware of why that needs to happen, or if we need to do an operative vaginal delivery, for example. And then we should make it our business and that we explain again the next day on the postnatal ward. So we encourage all of our O&G team to go and have a chat with them if they've been involved in the birth of a woman. And also we encourage the midwives on the ward to explain to women what's happening with them and what has happened with them on the birth suite. And then when they go home, the early pregnancy care midwife will chat through some of their experience in the hospital, and then again the maternal and child health nurses. But you as general practitioners have a huge role to play in this, because often you know these women, you've known them for a long time, and you will notice if they aren't in such a great place and whether they need some sort of support. So we've set up a maternity debrief clinic, and that's on the back of a lot of women having a few came through as patient complaints where they felt they had nowhere to go and they had questions that they needed answering. So really this is for those women who are still struggling and still don't know what happened, and they've got some unanswered questions. So it's an opportunity for us to sit with them and to review what happened around the time of the birth, and to explain to them so that they understand why we did what we did. For example, they may not have if we did a forceps delivery, we would always cut an episiotomy, but that message may have got lost in the general melee in the room. So just an opportunity to kind of explain, to see what happened, to see why things happened, and answer any questions that the parents might have. It is a small resource. It's only 3 appointments a fortnight, but as time goes on, if we find that we need to have more of a resource, then there may be an opportunity to expand that clinic. Also, if you've got, as general practitioners, if you see somebody who's birthed with us and you have questions around the birth, then you can always contact us and we can maybe have a look at the notes and see what's happened so that you can debrief them if necessary. Anyway, so we can do any questions now, or we can move on to the next bit.
Yes, how do we refer a woman to maternity debrief clinic, please?
Again, the clinic's only just started, and that's one of the, I would just send a referral into the PCC again. Just send a referral through. Yeah.
And then there was another comment. Yes, but how many women who do we see in general practice who you don't follow up for traumatic birth experience? I'm seeing them all the time.
Okay, so like I say, we've only got 3 appointments a fortnight, and the clinic's only just started, so we'll see where we get to. The point of the appointments with us is really information sharing. Again, like the Rainbow Clinic, we don't really have the capacity to do full counselling like CBT or anything like that. It is literally an opportunity to review the notes and go through. I'm sure that you see them all the time, and if it would be useful for the women that are sat in front of you to be referred in to get answers around what happened, then that's available. If they need more of a counselling role, then places like the Raphael Centre provide really good postnatal counselling. But I agree that I think it's much more of a problem now. I think expectations are very high around what birth experience should be, and I think women speak up much more about it as well, which is why 1 in 3 women is a lot of women have some sort of birth trauma, and it is a huge problem.
And another.
Sorry, can you hear me?
Yeah, if you come a bit closer.
We don't actually know what we don't know. So if you have people struggling in general practice, because we don't see them again, then please do write referrals in, and then we can address it. But otherwise, we don't see them very much after they discharge from our service. Thanks,
Tony. Another comment. Thank you for maternity debrief clinic. It's really needed. It is difficult to debrief our patients in general practice as we don't get enough information about the reasons for decisions taken. It would be good to get a report back.
A report back in what way? Because if I saw somebody in maternity debrief clinic, I would send back a letter covering what we covered.
Okay, I'll just wait and see if we get a response.
Yeah, there is a birth outcome letter that is sent out to all GPs that goes through what's happened in labour. But you're right, it's not in great detail, and it's often, that is difficult to put all of that detail into those letters, really.
And then just another question, does everyone get a debrief routinely?
They should all get a debrief on the ward routinely. But yeah, they certainly, if they've had an intervention, the obstetricians would go up and talk to them about the intervention that they've had. But even the women that have had a vaginal birth will talk to the midwives on the ward, and they should get some level of debrief if they've got questions. And I would encourage any woman to ask questions about what's happened in the birth, particularly if she doesn't know what's happened or doesn't understand.
Okay, from a GP perspective, the discharge summary really doesn't give enough detail to debrief very well.
I would agree with that. But it's, how do you get 12 hours of labour into a discharge letter? That's the tricky bit, isn't it? And that's the advantage we have, is that we have access to the notes.
Another comment, the information on the birth outcome letters is not detailed enough in these situations.
Yeah, Yeah, no, I agree. And we can go back and look at what we can change with that and see if we can put any more information in there. But again, like I say, if they've been in labour a long time, it's hard to put that level of detail into the birth outcome. But we can go back and see what we can improve on. So thank you for those comments.
Do many women bring in a doula or birth support person? It seems like this is becoming a bigger trend.
They usually bring a support person like their partner, and quite often they bring their mum as well. We are seeing doulas coming in, and a doula can be helpful but can also be challenging. So are you seeing doulas out in general practice more often?
I'll wait and see if there's something comes through on that.
But, yeah.
Just another comment.
COVID has limited the number of people that they can bring in labour. We're currently at 2 support people in labour. But I know in other units they've still only got 1 support person in labour.
Okay, I don't think it should be, what have we got here? I don't think it should be up to the woman to ask. It should be a routine recap of what happened. Does this create hindrance or support to the medical care? That
the
might have been
doulas.
in regard to the support person. Yeah,
the doulas are variable. Some doulas are helpful and some doulas aren't. And I think, and it can be a real challenge because they're not governed by a professional body. And when things go pear-shaped, there isn't any real recourse to answer those, there is nowhere for the parents to go if there's a problem.
Okay. There's a couple more comments, but I think we'll continue on with the presentation and we'll get to some more questions at the end.
Okay. So antenatal care guidelines. Now we've changed these slightly, and the drivers for change were we listened to women. There were lots of issues around our antenatal clinics, and these were the drivers of change. So one thing that I noticed was that a lot of women lacked confidence in their own pregnancies, in their ability to know whether the baby was moving or not, in just generally in confidence, their confidence in knowing what was normal and what wasn't. And that was something I hadn't really seen in the UK. And when I kind of scratched the surface, women come into the pregnancy care clinic, generally only see doctors all the way through, whereas I'd come from a system where the women are cared for predominantly by midwives and then would come to our high risk clinic at certain touch points, but most of their care was still delivered by midwives. And I think that continuity of care and that ability to sit with a midwife, and each time you go, you know this person, you don't have to go through the history all over again. Just that ability to kind of build somebody's confidence up and reassure them about what fetal movement should feel like, and kind of broach the subjects that are important around knowing when you're going into labour and knowing what's going to happen in the hospital if you're coming into hospital, or what's going to happen as a home birth, and some of the things that might happen that are unplanned, like maybe an emergency section. So all of those things, if you've got continuity of care and if you've got time with a midwife, then there's more opportunity to have those discussions and to inform the women. So one of the drivers for change was this aim to try and get some continuity of care. Also, I found that there was some women that were really low risk, and as doctors, we're really bad at sending women back to the midwives to be looked after by the midwives. And then you've got a woman who has her 10, 12 antenatal appointments. And the way our clinics are set up, it can be possible that you see a different person each time, and each time they take your whole history again, and like they just weren't getting any care from the midwives at all. So, and also too many appointments. Often people will bring in women back next week just because they didn't know what else to do. So what we were trying to do is to get all of us to think a little bit more carefully about what the purpose of antenatal care was, how we can improve the midwifery input so that they've got more opportunities to talk about those other things that as doctors we don't talk about, like collecting colostrum, like when to call, you know, what to look out for when you're going into labour, all these sorts of things. So what we've done is change the clinic's schedule, and the GPs that are local to us have had this sent out as a guideline, but this is really the care pathway, and this is useful in terms of just trying to give women appointments at times that are relevant to that are appropriate, and not to bring women to clinic to sit in our waiting room for 2 hours and then get seen in a very rushed way in 10 minutes, which is unsatisfactory for women, but it's also unsatisfactory for the clinicians looking after them. So if we've got a low risk, straightforward woman, she'll get booked by the midwife in PCC, and all of the women will get booked in PCC with a midwife, and they will take the history and they'll work out which pathway they should go on. And if she's got no risk factors at all, she'll go down the midwife's only care pathway. But if there are any concerns in a history, then the midwife will allocate her to, mostly they will go to an orange group, but really high risk women. This would be women, say for example, with Marfan syndrome, something like that would go into a really high risk group. So there's an extra appointment at 16 weeks for anybody where there's a concern about the level of risk, and that's an obstetric review where we can have a really good look at the notes and work out whether this woman needs to stay with us in pregnancy care clinic or whether we can send her back to the midwives. So in terms of coming to the obstetric clinic, they are only coming at certain touch points, and that's where we value add on top of what the midwives would do. So everybody comes to an antenatal clinic and we take a history, we check how mum is, how the baby is, test the urine, check the blood pressure, have a feel of the bump, have a listen to the fetal heart. And the midwives can do that and the doctors can do that. But it's only if we're going to give them some extra value that they'll actually come to us. So a lot of the women on the orange pathway will have growth scans performed. And this is why the women are coming in to see us at 28, 32 and 36 weeks. And that's to review the growth scans and see what else is happening. If they've got a higher risk situation, like I said before, there's very few that fall into these categories. We would maybe see them a little bit more often, and that's because we have concerns about the mum rather than the baby. But again, even in this pathway, they've still got a couple of midwife appointments, so that they're having that opportunity to talk through some things. The blue shared care pathway is either with you guys as GPs, or it's also for the CDU patients, or share care with privates. But again, there's a little bit of midwifery input there. The purple pathway is fetal medicine unit and preterm birth. These all tend to have individualised care plans, and some of them will stay in our unit, but some of them, for example, with preterm birth, once you get to about 26 weeks, the scans stop and they can just transfer back over to whichever care pathway is the most appropriate. We have seen a reduction in the number of women come into clinics since we've introduced this, because we've stopped the bringing somebody back next week because you're not sure what to do with them. And I think the women probably appreciate it as well, because the ones that are coming are being seen more timely. And then the ones that don't really need to be there can just go and get on with their normal lives, whether that's work or going out and doing other things. The antenatal care pathway in its entirety has been sent out to the GPs, and feel free to follow the template. We implemented this in May, and we're going to have a look at it in about 6 months' time and just see whether it all works, or whether everything works where it should be, or whether we need to move things around a little bit. But that's all I'm going to say about the antenatal care pathway. And that's me done. So any questions?
Yes, there is some questions. What percentage of women who elect to try to get into the midwifery-based program for antenatal care?
Between 17 and 20% of our women are getting to the MGP program. And what continuity of care is really important, and we've identified that certain groups will benefit more from the continuity of care, and so we've moved for example, young persons into the MGP program, rather than it being, it's being used for those that will benefit the most from that. We are looking, dare I say, we are looking at maybe providing a home birth program, which will expand the MGP program, because that will be undertaken on the back of that. But that's currently in the planning stage, and we just need to work out where we're going with that.
How do we get a copy of this new shared care pathway?
Are you a local GP? Have you not received it?
Yes, I think they are a local. Maybe they're not a local.
If Helen, if anybody wants it and they haven't received it, if you can just shoot me emails, then I can get Katie to send some out. But Katie Jones, who coordinates everything around the guideline and is the liaison with the shared care GPs in our department, she has sent it out to the shared care GPs, but we can send it out to anybody who maybe didn't get it.
Well,
or we can send it to PHN. Shall we send it to PHN, Helen? Is that okay?
Yeah, send it to me and I'll send it out to everyone that was here,
Yeah,
and
cool.
the GP, antenatal GPs, because there's quite a lot that have put in the comments after that to say that they haven't received it. So it doesn't look like anyone's received that.
Okay, I'm sorry about that. I'll send it to you,
Yep.
Helen.
Okay. Okay. Well, what else have we got here? So now, what is the difference between low risk and the MW-based program? The MW-based one is more continuity with the same MW.
Oh, you mean the MGP program? So the low risk is our midwives that work out of pregnancy care clinic or one of the satellite clinics, as opposed to the MGP program is more continuity. So the difference is that the MGP program, they come in and they do the intrapartum and the postnatal care as well, whereas the green low risk pathway is they get antenatal care with the midwives, and then they transfer to the hospital midwives for intrapartum care, and then EPC for the postnatal care. So that's the difference.
Okay, why is there not an appointment at 24-40 for the shared care patients on the new pathway?
You can have it if you want it. No, there's a 24, but we haven't put it. We put this in, so this one was put in to allow these women to get extra midwifery appointments. That's why. But if you want it in there, I'm sure we can put it in there.
Okay. It seems many women want MGP but don't get it as too popular and places are limited. Is this right?
Well, it's only delivered for 20% of our women. It is oversubscribed, you're right. I think about half get it, but it's not available for everybody. We just, it's a resource intensive model. And it's a great model, but it's very resource intensive. And I suppose it's a funding issue more than anything. Yeah.
Okay, how many high-risk women get seen by a senior doctor in PCC as opposed to a junior doctor?
There are always 2 or 3 consultants in pregnancy care clinic, and they, yeah, it varies as to how many. You know, we have a lot of patients to get through. There's usually somewhere between 40 and 60 patients in a clinic. And there's 2 or 3 consultants, so it's impractical for them to see absolutely everybody. But they will see some of them.
And someone has asked if they could have the name of the liaison for shared care GPs. If you can send that to me and I can pass that on as well.
Yeah, maybe I've given her a title that she doesn't normally have, but she seems to link with the shared care GPs. It's Katie Jones.
Okay. Yeah, I've got Katie's details actually.
Yeah.
Okay, let's continue on.
Okay, thank you.
Oh, hang on, one more question. How long are the midwifery appointments?
I don't have the answer to that question, I'm sorry.
Okay. Okay, that's it.
I'm sorry. Yeah. Okay, thank you.
Yep.
Good evening all. Apologies if you've already seen this presentation that was done about a month ago or so. So my name's Tony, I'm the Gynae Director at Barwon Health. I've taken the post around the same time as Dr. Masson about 2 years ago. In regards to the obstetric debrief, just to put a bit of context on it, the patients are usually seen the next day by the medical officers, the RMOs or registrars, where if there's any questions about the labour, they try and answer them then. If the person who did the delivery is available, and it's always on the vagaries of the shift workers, they try and also attend to do a debrief. All the day 1 Caesars are usually seen by their primary registrar surgeon. But then after that, it's very hard for us to know who may still have some degree of psychological stress or confusion about their events. So like I said, we don't know what we don't know. And we would always be very happy for you to just write a referral in and we can triage it and try and get the same person who was at the delivery to see them if it's just what happened that day. Because I agree, our discharge summaries are often late and limited. And we're always happy to see people who are confused about what happened. Whereas the obstetric debrief clinic, the more formal one with the 3 sessions per fortnight, can be for more complicated technical issues as opposed to just what happened that evening. That's pretty much it there, mention. Yep. So this is I suppose what this evening is just to try and share some of all the new things that have happened the last 2 years. It's a really exciting time for our department. As you can see, we're starting to be able to offer a lot of the services that were only available in Melbourne, both from an obstetric and gynae point of view. It's lots of services that now we can help service our local community and avoid having the difficulties of having to go up and down to Melbourne or loss of care due to an inability to get up to Melbourne. So this is the gynae team, essentially myself, my gynae clinic nurse, Rebecca Murnane, and then my 2 gynae bookings nurses who coordinate theatre bookings. So Sarah and Courtney. So many of you will know that we've undergone a big change over the last few years. We used to have a real bottleneck in gynae reviews and surgery. So prior to my arrival in 2017, gynae patients were seen in private consultant rooms. They were then sent to Barwon Health if surgery was required to meet their primary surgeon. And basically Barwon did a pre-admissions clinic, met their primary surgeon, completed the consent, and off they went for surgery. From 17 to 21, what happened is that we had a general public gynae clinic. The trouble is this was serviced by only a handful of consultants and was run once a week. And in a very rapid period of time, we had over 1,000 patients with a 3-year wait list. And what happened is that the government only saw the patients here once the patient had a consent completed. So private rooms would see people, there'd be a long wait to eventually get to meet your surgeon. You get your consent completed and then you'd have surgery. But this part isn't captured by the government. So there were 200 patients waiting up to 3 years. And if you came to the public service, because you were seen by the consultant who wasn't going to be your primary surgeon, again, there was a big hang up here that was invisible. And this was unsatisfying for both doctors and for patients. So what we've done since then is we've changed things so that this should say 2021. Private rooms, if the patient wants a minor operation, we can get on and consent the patient, write a decent note, referral, they can go straight to theatre. So this is all documented wait time. Or if they need a major, they come to Gynae clinic. And then also if you send as a GP a patient for a first Gynae review, they come down this pathway. And again, they're seen and they sign their forms, but because every consultant does Gynae clinic now, they get on, sign the forms, they're captured in the system, and we have an honest reflection of our actual demand and numbers. So we've got rid of the invisible wait time. There is no pre-admissions clinic or double handling. What is actually happening within our system is reflected in our numbers. There's continuity of care in terms of the consultants and the registrars. Seeing the patient, and then also we try and get the registrar and consultant to see the person post-op as well. So we're trying to improve our flow and continuity. There's a fair distribution of work within our department. And also with our triage system that we started back in 2017, the patient's referrals are triaged to the correct consultant. So someone who needs a vaginal issue sorted will go see a prolapse surgeon, and someone with something that may be a laparoscopic subspecialty issue will see one of the laparoscopic subspecialists, etc. And in the interest of fairness, everyone's operation date is judged from when they were referred to the gynaecologist, either public or private, from yourselves. So patients who are seen in private won't leapfrog public patients because they were seen faster or were more efficiently managed. And so this is really important just to provide some fairness to our system. So you can see in this slide here, we were really struggling. The numbers in terms of gynae referrals went up astronomically, and the total waiting list was rapidly increasing as we couldn't see them fast enough. And then with our new system, you can see that we've managed to drop the total waiting list from over 1,000 down to, thankfully, as of today, down to 300. And this is despite a COVID pandemic. So at the moment of those 300, everyone has a date except 100 patients, and the routine wait time for first visit is now down to 4 months from many years. So we're actually in danger of running out of gynae patients, which is why I'm talking to you. In terms of surgical wait list, you can see again, we had a dramatic increase in gynae operating from, got all the years have blurred a bit, I think it was March 21 or something like that, where the old Geelong private was opened up. And so we managed to get our surgical wait list down to less than 100 from over 1,000 cases. And then Code Brown happened and we're back up. But you can see even the last, that's actually supposed to be today. So, there's about 300 patients waiting for surgery. And you can see our category 1 wait time is if you come in and need an operation, a category 1 minor for, say, postmenopausal bleeding, we can, at the current moment, give you an operation date within about 2 weeks, which is probably better than anything we can provide in private, at least anything better I can provide in private. You can see our category 2 wait list, which used to be years, has now come down to 139 days, and even in the last 2 months has come down to 72. And you can see category 3, so ladies who used to be waiting years for prolapse surgery or incontinence, we're waiting to 3 years, as was a year about a few months ago, is now down to almost 6 months. So you can see the Gynae service hopefully is providing a much better service to those locally. And we're trying to dispel the myth that if you refer to public, it's going to take you years to be seen, because the patients now come to clinic going, oh, I've got an appointment so fast, I was told it was going to take years. And it's really important we get this message out there, where we want to be a premier service. In terms of overdue waiting times for surgery, you can see that we got it right down prior to Code Brown, and then we creeped back up. I don't have the most recent numbers, but I expect with the short wait list times now, we've probably dramatically dropped again. So since 2017, we've gone from 1 Friday morning clinic a week to 4 half-day sessions per week. So we've gone from seeing 30 patients per week to over about 130, COVID God's willing. We've also opened up the colposcopy service to everybody. So previously, colposcopy was only to healthcare card holders and pensioner card holders, which I felt was incredibly unfair, or we all felt was incredibly unfair, because we've rolled out a new screening program that then requires a colposcopy, but then the patients can't access colposcopy in a public setting. There was only private access, which had a fee or a cost, or relied on the specialist to provide a bulk billed service. So as of today, we have a wait list of 78 women for colposcopy. If it's a routine colp, you will be seen the patient will be seen in 4 months. And if it's an urgent one, we'll overbook and have them seen in 4 weeks. This is a free service that previously would probably cost most patients in private world about $200 with a semi-buck rebate. So this is something that we're extremely pleased about, and please refer to our service to be able to sustain it. You've heard about our new clinics where we try and improve and streamline our Gynae service, so obstetric patients aren't coming to our Gynae service anymore. We now have FDIU, Rainbow Clinic, Debrief Clinic. We've now got a subspecialty a perineal trauma clinic, again, and one of the first ones outside of Melbourne, run by one of our good colleagues, Dr. Deb Carmarker, and we're getting an endo-anal ultrasound probe as well as anal manometry to really be able to counsel people about their options for next pregnancy, which was previously incredibly difficult to access even in Melbourne. So in summary, in the last 2 years, we've managed to get our wait list for urgent appointments from 3 years down to less than 6 months. We have urgent appointment wait lists basically we can see anyone within 4 weeks if you're particularly worried and you make it obvious in your referral. And our absolute numbers have gone from 1,300 down to 300. And my actual concern is if we run out of patients, I'll have to give clinics and theatre time back, which would be a shame because it took so much hard work to get them. So we have built it. We have built it, but we need to fill it. And we want good referrals, but I suppose what I'm trying to say is we have a service that's ready to go, and we just want you all to know that the wait list is no longer years. We have subspecialty surgeons now in terms of prolapse, continence, laparoscopic subspecialists. We've got people with an interest in menopause, fertility, even though we don't have a fertility service. We can run basic clomid cycles. Our intention is to have a vulval subspecialty clinic, and we would like to have a fast track clinic for contraception, IUDs. There's a plan to perhaps get outpatient hysteroscopy. We really want to improve recurrent miscarriage. We really want to improve our communications to yourselves. So every registrar will be nagged that they should, and RMO should be nagged that every time they see a patient clinic, you should be getting a dictated letter. And if you are having frequent issues where this isn't happening, please let me know. The irony is that my public patients have better correspondence to you than my private patients. Apologies for that. So how to make referrals to Gynae Clinic. Please use, unfortunately at the moment, you still have to use a surgical outpatients template, but it will come to us. I'm still talking to the GP liaison unit about trying to get a Gynae head blind referral, but essentially this will do the job. You can fax to us. Non-urgent queries, you can email Beck at Gynaecology Clinic at Barwon Health. The ONG reg, there's always a Gynae reg available with a mobile phone on them. And I'll put it up here because sometimes a quick phone call can just aid either your referral or management process where you don't even have to refer them to us. They are often busy, so if you leave a message or text, they'll do their best to get back to you. If you're really desperate and can't get through via the reg, you can always call the consultant of the day, or you can email me, or probably many of you already have a consultant that you've got their mobile that you just ring or text for, quick corridor consults or advice. But we want to be an approachable service, we want to be an excellent service, and we want to be a busy service. So thank you for your time, and please refer and help us provide a wonderful service to the women of Geelong and the greater region.
Okay, Tony, let's go here. How do we refer women for colposcopy for HPV through public clinic?
There is on the whatever that there's a colposcopy thing on the healthcare pathways, the same as for what you do for gynae clinic. There's a click and flick thing. And you can import it into your practice management. So whatever this thing is here, I suspect all of you will know better than myself. But there is a template for Colp Clinic. Otherwise, if you're desperate, I suppose you could always put through a general gynae clinic and we'll triage it. Basically, Beck triages everything, and anything that she's not quite sure, she runs past me. So the more information you can put in your referrals, the better, as always. And then if unsure, often many of you have got a letter back from me asking for additional information or advice that might save the patient.
Just a couple of comments. Yep, good to know. Thought it was still years waiting. Pretty much aren't referring any gynae to public with previous issues. So this is great to hear, especially for colposcopy.
Yes, exactly. And this is where I've been a little bit worried, is we've transformed the place, but no one knows about it. And so many GPs and so many patients are going, oh, I thought it was going to be years. It's like, no, this is faster than private, or at least equivalent to the speed of private.
Still some more comments. Amazing effort. Well done, Tony and team, and thank you. Is there any IUD clinics and question mark training for GPs?
Yes, there is a IUD clinic so far as we've got a nurse practitioner who does insertions if they're straightforward heavy menstrual bleed or just reliable contraception. If you have someone who's socially disadvantaged or at danger of unplanned pregnancy, if you put that on your referral, I will fast track it. So again, if you have anyone of social concern that needs urgent contraception, put it in the referral. She'll be seen in 4 weeks and sorted. The long-term plan is to have a contraception clinic. Ideally, perhaps with one of our, and we would always be happy for GPs to either be involved in the clinic or run the clinic. One of our sort of newer ideas is that maybe some of our career medical officers may have a special interest in terminations or in choices clinic or contraception clinic, or help run a heavy menstrual bleeding clinic. So I think we're only limited by imagination. If you come up with ideas, we can try and make it happen. In terms of Myrena upskilling, yes, the more I can Myrena upskill, the less that come to us, which is great. And then we can get the difficult ones or the hard ones. My issue is more, it's very hard to be competitively remunerative. I think the best I can get a GP is about $90 an hour. But in terms of education, we're always happy for you to come along, or we can get your clinics where you have back-to-back Myrenas to upskill. So just reach out and we can arrange stuff.
Okay, how about updating the pregnancy template? Perhaps disappeared 2017, it's still on the template.
Yep, it's a very slow process of updating our forward-facing web pages. So we've just updated the Gynae web page that used to be from 2013-14. We've updated the front page that says we're only a pre-admission service. We're doing our best as quick as possible with what limited hours in the day we have.
And where is this template?
Which one?
Uh,
The surgical
must be the-
outpatients template. If you go to, can you still see my screen?
Yes.
I'm pretty sure if you go Barwon Health, it's literally off the website. If you go to clinics, services and departments, there's a choices. I think we fall under women's health or something. I have done this so many times and now we're on the spot. It'll be somewhere in here. Keep asking the questions whilst I do this.
Okay.
Yeah.
Would love some better electronic correspondence for antenatal shared care or centralised document like previous manual book at VMR.
It was a handheld, physical handheld record.
What we would actually love to happen, is that we all write into the same system. And
Can you go closer to the microphone?
yeah, sure. What we would love to happen is that if you've got a shared care patient, that we all write into the Baby Boss system. And that is being trialled. Katie's trialing that with a couple of GPs to see if we can get that to work. Because it would make much more sense if you can access the same information as us. We are looking, the hospital is looking at a new electronic medical record, and we're looking at maybe getting a different maternity system.
I suppose there's no reason why you, as a GP, couldn't ask, like, create your own handheld record that the doctor could scribble in very briefly, like the old handheld record. I don't think. Like,
what we can do is, what should happen is that the patient has the print off of their appointment given to them when they leave, but a lot of them don't want it, and that needs them to carry it around as well. So really, in this day and age of technology, we should just all have access to the same electronic record, and that's the direction of travel in terms of looking at what should be happening with our new EMR.
apart from the short term, maybe just give the patient to ask for treatment and then give them time each time they come to us. Like, it may need a bit of nagging, but that may be where the patient empowerment is required until the technology catches up. So this is GP referral templates just off the Barwon Health website. So this is the Colposcopy link, and there's some way that you can get it into your practice software. You guys will be more, you'll all be more familiar with that than myself. There's choices or terminations, there's the pregnancy care clinic, and like I said, Gynae, unfortunately, at the moment still comes under the surgical outpatients department, but that's a work in progress.
Okay. This was a comment, must have been from one of your questions. That will only, Tony, that will only work with communication. Please ensure that all consults are sent. Definitely.
Or in regards to antenatal or Gynae?
I think it might be Gynae.
Gynae, every time a doctor sees the patient at clinic, they should be writing a letter. I apologise, our discharge summaries is particularly backed up because we just have so few junior staff, and we keep trying to redesign the roster to make it better, but it's an ongoing process.
Okay. I will pass all these comments on to the speakers, and they possibly will respond to you. Definitely there's one here, definitely keen to be invited in clinics with GP input if this comes about. Good communication flow is great for patient care. All of the other clinics are Barwon Health pay GPs as a consultant, new peds, derm, public health unit. You shouldn't be restricted in paying GPs competitively.
It's an ongoing issue with HR. Our issue is very much with FTE. We need obstetric after hours and cover. So the clinics, this is a conversation for a different area, but it is an ongoing issue. It's not because we undervalue you. It's just very difficult to get it past the levels above us.
And so to be clear, just fax to surgical outpatients for colposcopy clinic?
On that fax number, or you can do it electronically through that link that I showed you.
Choices is under social work. There's a comment here.
When I just went to that, if you can still see my page, choices is triaged by social work due to its time critical nature. So if you do this one, where was it? I saw it earlier. Choices, top. Yeah, Gynae choices. If you click the link, I assume I can't do this off my computer because I don't have the practice management. But there is actually, we just did the Gynae choices front facing homepage. So there should be instructions on. We've just changed the front-facing page for choices. I don't know what we fall under, W for women's or maybe G for Gynae. Like I said, I've just done all this, and I apologise that I've been on the spot and I can't find it now. Choices. Sorry, I'm showing off my gynaecological ability. But yes, choices is triage by social work.
Okay.
Oh, here we go. Yes, found it. Sorry. Outpatient services. So there's referral information here. There's and pregnancy choices information here. The social work department phone number's there if you need any urgent advice. And then if you click this link, it's got the one that takes you to that template we discussed earlier. And there's a fax number for choices there. It is, like I said, this is very much a work in progress. It's IT is not, and data presentation on times of websites is not my strong point.
Okay, if you want to, even if you want to send me the links, the easy links from that website or whatever, and I can sort of send it out in a bundle with the.
The GP liaisons are the ones who coordinate a lot of this as well. So
the
Jeff
GP liaison, Jeff Urquhart, and
and there's another doctor there. I've forgot his name on the spot.
Okay. All right, well, we might finish up on that note. Thank you, everyone, for attending. Special thank you to all our presenters. Some really good feedback and comments that have come through. So I'm going to pass all those on, and I'm sure that the speakers will respond if if they need to, and they're going to send me through the pathways and stuff like that, I'll send through that the name of the person in the pregnancy care clinic that you can liaise with. Have I covered everything now?
Yeah, give us feedback. We want to know what we can do better.
Okay, yep. There's a evaluation that'll go out straight after this, so please put all the feedback and suggestions or whatever you want into that. Plus, if you want to hear anything else in our next pregnancy care update, pop that into the topic requested, please, so that we can address all that at our next one. So thank you so much for presenting. It was a really great presentation, and we'll see you at our next one.
Brilliant.
Bye.
Thank you all. Have a good evening.